Welcome everyone to our live JACC CardioOncology Virtual Journal Club. My name is Dr. Bonnie Key, and I'm the Editor-in-Chief of JACC CardioOncology. Today, we will be discussing the original research manuscript published in our September issue, Left Ventricular Systolic Function in Long-Term Survivors of Allogeneic Hematopoietic Stem Cell Transplantation, presented by first author Dr. Richard Massey. This will be followed by an in-depth discussion with all of you and with members of our panel today, including Dr. Neil Bhatt, who is co-author of the accompanying editorial with Dr. Navneet Majal, and members of our editorial board, Dr. Sara Minian, Ron Watellis, and Anju Noria. I want to remind all of the attendees to please use your chat function to answer questions as they come along, and we'll do our best to answer these and respond to these. So before we get started, I just wanted to make a comment about this paper. I selected this article for a journal club because of its really excellent and strong execution and what I believe is its potential to inform clinical practice. I also think it's very important to highlight the cardiovascular concerns in the transplant population, given the growth of this population as well as the burden of cardiovascular risk factors and disease. With that, I'll hand it over to Dr. Massey to give us tell us about his paper. Dr. Massey?
Thank you very much. On behalf of my co-authors and myself, I'd like to thank you for giving me this opportunity to present in this article. This study was conducted at Oslo University Hospital with funding from the Norwegian Cancer Foundation and the Extra Foundation. I'd just like to present some background information. In 2018, almost 43,000 patients received stem cell transplantation, of which 43% of them were allogenic. Myeloid leukemias were the main reason for stem cell transplantation. However, indications have diversified, and it is increasingly being chosen as a curative therapy for malignant and non-malignant diseases, particularly in young recipients. With advances in technology and treatment, there is improved survival rates as compared to earlier. However, these patients have lower long-term survival. For example, in those that survive the initial first 2 years, only 80% have the probability of surviving or living to 15 years. The main causes of death are relapse and chronic graft-versus-host disease. However, the risk of cardiovascular-related mortality is 2 to 4 times higher in stem cell transplanted survivors than in the general population. And it seems the risk increases from the time of transplantation and differs between those transplanted as young or adults. These patients also have a high prevalence of post-treatment complications. While heart disease is well documented in survivors of cancer therapies, there's much less information about allogenic stem cell transplanted survivors, particularly those treated in their youth. There exists several studies that have reported on heart failure in these patients. The incidence of heart failure has been reported to be up to almost 11% of those who have survived 10 years. Heart failure has been attributed to therapies given prior and during transplantation, but also because of the high rates of cardiovascular risk factors. So the objectives and aims of the study were first and foremost to describe cardiac function in a Norwegian cohort of long-term survivors of allogenic stem cell transplantation who were treated in their childhood, adolescence, and young adulthood. In order to do this, we used modern echo techniques, including 3D imaging and speckle tracking, to measure global longitudinal strain that's been identified as a useful marker in cardiac toxicity. And finally, identify the relative role of different risk factors in the development of left ventricular systolic dysfunction. The methods. Well, this study has benefited from the fact that in Norway, Oslo University Hospital is the single center for stem cell transplantation. And hence we were able to invite all living survivors in Norway to participate in a cross-sectional study. 104, approximately 66% of eligible survivors were included. Inclusion criteria was stem cell transplantation at Oslo University. They were aged less than 30 years old at transplantation, but older than 16 at inclusion. And there was a minimum of 5 years follow-up time. Clinical examination was conducted, including patient treatment history and current health status. To evaluate heart function, we used echocardiography, and we used traditional 2D imaging, we used 3D imaging, and we used speckle tracking to gain global longitudinal strain. This was performed and analysed by the same experienced examiner who was blinded to all medical records and patient and control status. We defined left ventricular systolic dysfunction as reduced 2D EF by gender, which is according to the 2015 cardiovascular imaging guidelines, and GLS as greater or equal to -17. We made a special effort to obtain a good comparative control group. In particular, we recruited individuals with similar distributions in age, gender, and BMI. The only exclusion was prior known cardiac disease. Statistical analysis included comparisons between groups and controls with propensity scoring, linear regressions with EF and GLS, and in-group comparisons with ANCOVA to evaluate dose-related effects of anticyclines. So the results, and firstly the patient characteristics. Approximately 17 years have passed since time of transplantation, and the majority of the patients were middle-aged. The majority were treated for malignant diseases, and 45% had received anticyclines prior to transplantation at a median dosage of 270 milligrams per meter squared. Standard conditioning was based on busulfan and cyclophosphamide. Stem cells were obtained from bone marrow at 85% and from unrelated donors in 30%. And few survivors had had radiation therapies or total body irradiation. From clinical examinations, we found that the majority were asymptomatic, being in near class 1, and were generally physically active. We looked at the risk factors, and we saw that 64% had a previous history of graft versus host disease. This was either as acute and chronic. At time of examination, we re-evaluated these, and 43% was now resolved. We also found high rates of cardiovascular risk factors as previously published. And then we found 40% hypertension and 15% hypocholesterolemia. However, the majority of these patients were currently under suitable medication. In fact, 32% were receiving some sort of cardioprotective medications. So now onto the echo results, and the echo images were good, which allowed high viability. Here is the essential illustration which was published, and as you can see, the blue are the controls and the red are the survivors. At the bottom, we have some parameters of echo. We have two-dimensional ejection fraction, three-dimensional ejection fraction. We have global longitudinal strain. This is an absolute value. And we have MAPSA, which is mitral annular plane systolic excursion. As you can see, the survivors have lower values for all of them, which represents differences or lower systolic function. And all of the parameters were highly significantly different. In general, the dysfunction was from subclinical to moderate, as expressed by the group means. However, we did also see that the survivors had smaller diastolic dimensions. When we controlled for cardiovascular risk factors, we also saw that they had lower cardiac mass. EF and GLS correlated, however, they measure different modalities of systolic function. When we defined left ventricular systolic dysfunction, we found that in 44%, of which the majority were asymptomatic. From regressions, we found there were slightly different predictors for EF and GLS. However, anticyclines were a common predictor for reduced EF and GLS. When we had a closer look at the echoes, we found that there was a dose-related response. In that, at high dosages, we found that the function was much lower. We also saw here that there were slight signs of remodeling, particularly with cardiac mass. The study does have some limitations, and that is that it's a cross-sectional design which describes only associations. It would have been nice to been able to see when or the timing of the initial myocardial damage, or concluded the deterioration of the left ventricular function was part of a progressive continuum. Likewise, to see if reductions in GALS are followed by reductions in EF. This would have been answered with a prospective study. We have limited knowledge of the non-participants, including cardiovascular status, but non-participants were younger and had shorter follow-up time, possibly leading to overestimation of left ventricular systolic dysfunction. The study does have some advantages though, and these are that there's completeness of the cohort, nationwide patient inclusion, long follow-up, standard transplantation regimes with minimum confounding from radiation. We consider the data collection to be comprehensive, of high quality, including modern echo techniques. And in conclusion, this Norwegian cohort included 104 long-term survivors of allogeneic stem cell transplantation who were treated in their youth. We found left ventricular systolic function to be significantly reduced when compared to healthy controls. Significant predictors for reduced systolic function were anticyclines and hypertension. In addition, we found a significant dose-dependent effect on left ventricular systolic function. We consider this method to have several clinical implications. Firstly, potential benefits from screening and follow-up regimes with echocardiography using strain, and assessment and treatment of modifiable cardiovascular risk factors and education in lifestyle factors. Hopefully, this would reduce the life-threatening effects of heart disease and promote better quality of life in long-term survivors of allogeneic stem cell transplantation. Thank you.
Thanks so much, Dr. Massey, for that excellent presentation and your excellent paper. Congratulations. So high prevalence of LV systolic dysfunction, and many of the survivors were asymptomatic. We have some questions coming into the chat, and I encourage folks to keep on entering those. I wanted to open it up, though, to Neil, Dr. Bott, and Dr. Armenian at this point to tell us a little bit about the significance of the problem in terms of the prevalence, what you are doing in your practices in terms of screening these survivors.
Yeah, thank you, Dr. Key, for inviting me. And both Dr. Majhel and myself felt that this study was nicely done. And I congratulate Dr. Massey and all the authors for doing this work. As you pointed out, Dr. Key, cardiomyopathy and congestive heart failure is a known problem in transplant survivors. However, we don't really know the magnitude of this problem because most of the studies that have assessed this outcome have relied on the registry and self-reported data to understand the magnitude of CHF. So by that time, it's already an overt problem. So it does not give us an idea about the subclinical LV dysfunction that precedes this overt heart failure. So that is why this study is important, and it actually shows a higher prevalence of LV systolic dysfunction by doing some advanced echocardiography imaging technology. So it definitely adds to the literature, and I hope that, as Dr. Massey pointed out, we will see, this study will help us revisit the discussion surrounding routine screening in the childhood, adolescent, and young adult transplant survivors and discuss the type of screening techniques. And also, we'll open the discussion about primary and secondary prevention and risk prediction in this vulnerable population.
Thanks so much. And bringing to that point about cardioprotective medications as well, I'd open it up to Anju, Ron, Saro, do you commonly prescribe cardioprotective medications? Which ones do you use? ACE inverse beta blockers. There's a question also about whether or not dexrazoxane is used, presumably with at the time of anthracycline administration.
Maybe, Sarah, do you want to address the anthracycline one, and then maybe Andrew and I can talk about the cardioprotective?
Sure. Yeah. So, so just backtracking real quick, I think one of the other areas that to highlight for this paper is that there's a tremendous amount of heterogeneity in terms of screening and management of these long-term patients. So what, one of the great things about this paper is that we're talking about individuals who are 10, 15, almost 20 years out from their transplant, and we know so little about them, about their physiologic health. And so we're not able to make recommendations for long-term management and long-term screening, and management includes cardioprotection in these individuals. So this is an important first step in helping to address that gap of what's happening to them. As far as dexrazoxane, I think the role of that is really in the context of anthracycline administration, which really happens prior to the transplantation process, and I think that's a whole discussion of itself. I think aggressive management of cardiovascular risk factors is really what we are focusing on and what we have focused on clinically. As far as preemptive use of cardioprotectants, beta blockers, and other agents in individuals who have normal systolic pressures and other sort of risk factors, I think that is an area that is wide open and understudied, and we really don't know how long and at what point and what thresholds to target for this particular population.
Yeah. Ron?
Yeah, thanks. I too thought this was a really good and informative study. It's more than anything, it's addressing an area that we're really just lacking data in, and to be able to provide this kind of detailed analysis on reasonably long-term survivors is an important addition. I'd say my take is a couple-fold. One, that I still think that the data from this supports that probably the biggest risk factor is still the anthracycline administration. And I think when we're thinking about who should be screened, in my mind at least, I still really separate that out. So somebody who had a stem cell transplant, who had received anthracycline, to me remains very different from somebody who hasn't. And I think when we're thinking about should people have screening cardiac imaging down the line, that's probably an important differentiator. In terms of what to do if you find borderline or mild LV systolic dysfunction, as Sarah was getting at, the true answer is we don't know. The data is pretty poor. I think there was a lot of enthusiasm early in the development of our field for giving ACE inhibitors and later beta blockers, but particularly in a setting like this, years out, an ejection fraction in the low 50s, it is not clear at all that doing so will be of benefit to a patient. And now you're committing somebody to a probably lifelong medication. To me, I would restrict that to people with true LV systolic dysfunction. We could quibble about what that definition is, but for me, you're certainly going to be below 50% ejection fraction. And I'll just close my comments by saying, even in some of the old SOLVE data with ACE inhibitors, with people who are asymptomatic with really low EFs below 35%, you couldn't show a mortality advantage, and even the impact on heart failure hospitalizations was pretty modest. So just getting that, it's important to recognize when we look at our interventions, how big the impact can be. And I think for really mild LV systolic dysfunction, I agree with Sarah, it's more probably about risk factor modification than it is starting quote unquote cardioprotective medications most of the time.
Thanks, Ron. I can see that there are a lot of questions and people are really seeking clarity in the chat about, and we've tried to answer these, but just to really drive home the take-home messages: who should be screened, when should be screened, and how to be screened. I think I'm hearing that or reading that through the chat. I think it's based upon this paper. What would each of you recommend in just very granular detail, recognizing that of course we need more data and we need better guidelines. There are COG guidelines, there are Lancet harmonization guidelines, certainly, that would encourage everyone to also read and review. And of course, the ASCO cardiac dysfunction guidelines. But what would each of you recommend based upon this paper, and how does this paper help move the needle forward? At least one screening echocardiogram based upon, in part, anthracycline dose is a little bit what I'm hearing from Ron. I'm also hearing that aggressive modification of cardiac risk factors. But anything to add? And Dr. Massey, Anju, Dr. Noria?
No, I think I agree with everything that Saro and Ron have said. The guidelines currently recommend the frequency of screening based on what the anthracycline and radiation dose has been, with more frequent screening in people who have received either high-dose anthracyclines, high-dose radiation, or any combination of the two. I think the screening intervals that are currently recommended by the COG guidelines might be too frequent for people who have received low-dose anthracyclines. And I think the current recommendation of lifelong screening also needs to be sort of reevaluated, because it imposes a significant anxiety burden on the patient and also imposes a significant health cost on the system. And so if someone has had completely normal systolic function, and let's say we add GLS going forward, given all the new data regarding GLS as an early marker of systolic dysfunction, and if someone has had normal studies for, let's say, 10, 20 years after their treatment, should we continue to monitor that person going forward? And if so, should the frequency of that monitoring decrease? And I think these are all unanswered questions in the field that ultimately rely on the physician taking care of the patient and what their level of anxiety is.
Thanks, Anju. I wanted to highlight some other questions that are coming through the chat, although admittedly not necessarily addressed through this paper. There are some questions coming through about GVHD, which was addressed in this paper, but risk of coronary artery disease, and also what is the role of statins. Saro or Neil, if you could talk a little bit about the risks of GVHD and the subsequent cardiovascular consequences. And then Andrew and Ron, if maybe you could comment a bit about your use of statins, and also Richard, how you're caring for this population in terms of statin therapy.
I can just briefly just start by saying, so there was initially animal data to suggest that graft versus host disease itself sort of results in endothelial injury that then accelerates the process of arterial disease in allogeneic transplant patients. I think as people have been studying allogeneic transplant patients, they realize that the graft versus host disease effect isn't necessarily direct organ toxicity or endothelial function toxicity. That may be there very subclinically. A lot of it is really the burden of the modifiable risk factors that emerge due to the medications that these people are on for the treatment or management of graft versus host disease. So this includes steroids that they're on chronically, or cyclosporin or calcineurin inhibitors, and other medications that can affect both kidney function, that result in dyslipidemia, hypertension. And I think the cumulative burden of these medications used to manage GVHD really drive the GVHD related risk. So again, it goes back to this issue about better control of these risk factors, and the GVH specific effect may not be as impactful as we used to think.
Interesting. And the role of statins?
I would say at this point unknown, depending on, so people have looked at subclinical disease, they looked at coronary calcium and the role of sort of when to initiate statins in this particular population. I think given the uncertainty in the general population for when to initiate them in individuals who have, let's say, just CAC score thresholds, et cetera, it gets even more complicated for this population, so we really don't know. But an area that's understudied, I think the one thing that people are starting to think about is that there is an accelerated atherosclerotic phenotype that we see, again, not because directly due to the GVH, because of the high burden of these morbidities. So maybe there is an accelerated process similar to what you would see in HIV patients, for example, as a result of the medications that they're on. And so an area to study how aggressively, when, and what agents to use in these individuals is definitely an area to focus on moving forward.
Great, thank you. Others, Richard, specific questions for you about relationships between LV mass that are seen with high blood pressure, specifically in your study. Did you see any relationships there? And how specifically also did you define hypertension?
Okay. Well, hypertension was defined as systolic pressures over 140 and diastolic over 90, and or use of medications for hypertension. That was how we defined hypertension. In regards to effects from patients with hypertension, we saw very little remodeling in this patient group. We didn't see much signs of hypertrophy of the left ventricle. So that's interesting. But then again, the majority of them were receiving medications for this for hypertension. So maybe that was the reason why. Again, also that they are a very young population, still they're only 30 years old, and we didn't know how long they actually had hypertension. So, yeah.
Great. Okay, thanks. Thanks for that comment. Some very nice comments coming in from Eric Yang, Arjun Ghosh, and Avi Guha, just about potentially the role of CHIP here in terms of a screening tool, or even maybe Eric points out a confounder with GBHD for ASCVD assessment. I don't know if anyone wants to comment on CHIP, Neil or Saro. And also Eric interprets this data as implies long-term screening as indicated regardless of dose, but degree frequency needs to be addressed. And also questions about who should actually be doing the screening. If folks could comment about your practices in terms of how are these patients getting referred?
Well, I can comment about the situation in Norway currently. We recently started with cardio-oncology specialists. It's taken a while to get started, but now we have started, and we're especially, it's not just these, but we're also training the nurses and the sonographers who are performing the echoes. So I think that's also a very important component, that we get better at this echo techniques, especially with the use of strain. So I think that's one component that needs to be taken in consideration when we're doing the screening.
High quality imaging, ensuring that there's reproducibility in the measures. Certainly, we talked about that a little bit before the discussion started, that the paper was very nice. It used very advanced measures such as GLS, as well as 3D echocardiography. But certainly there's a need for high image quality in order to obtain high quality data. And there may be still ways for some of these measures, particularly even 3D, for implementation into real world clinical practice.
Yeah, I mean, but I always worry that if you find somebody who has, they're whatever, 15, 20 years out from their treatment, and they've got normal looking ejection fraction, and you see some modest GLS abnormality, and labeling them as now having cardiovascular disease is, I don't know, I worry about, and I'm not sure that we're doing them a favor at that point if that's the only abnormality that they have that far out. So to me, I think it's this sort of data is really important in terms of understanding what the natural course of the disease is. But I would be really hesitant to look at this and say, gosh, we should be doing GLS measurements 20 years out or 15 years out to find super subtle abnormalities to the extent that it's even real and the person doing it is really knowledgeable. I think there is a real danger with what I would call over-screening there.
I mean, maybe one way to look at it is if you did a cross-sectional evaluation like was done in this study, and you found someone did have abnormal GLS or a borderline EF, that could be a person in whom you actually do a follow-up evaluation more frequently to kind of see if there is a progression in their disease and then intervene as needed. So it could be a way to kind of influence your frequency of screening, rather than necessarily an actionable item in terms of treatment unless they had overt dysfunction.
Certainly true. In the sense that I think also impress upon the providers and healthcare system and physicians that to very aggressively treat those modifiable risk factors and use that as additional evidence potentially to the patient about the importance of controlling blood pressure, exercise, treating lipids, and so forth.
I just wanted to make a point about the role of genetic mutations. In this study, we found that the prevalence of LV systolic dysfunction was there regardless of the anthracycline dose, and the heterogeneity that we see in our population for this type of cardiovascular outcomes brings up the point about potential role of genetic mutations. And there have been several genes identified and SNPs that affect the metabolism of anthracyclines. So there is definitely a need to include those in subsequent risk prediction models. And also the role of CHIP is still under investigation. There are several groups looking at the donor-derived chips and how that impacts the long-term cardiovascular outcomes in transplant survivors. So hopefully we'll hear more in the near future.
Great. Well, thanks so much. We're closing in on the half past of the hour. So I wanted to thank everyone for joining our live JACC CardioOncology Journal Club. I hope you all learned a great deal. I know I did, certainly, from this fantastic paper, which is certainly a step forward, and agree with everyone that we clearly need additional research in order to continue to inform the guidelines, which we hopefully will see one day in the future through such studies. I wanted to announce to everyone to look to our next two issues in 2020, publishing November 17th and December 15th. I also want to note that our November 17th issue is a special additional one, given the quality and volume of content we've received from all of you in the community. So thank you. So thank you to our wonderful panelists and to Dr. Massey for presenting his paper. And I hope everyone has a terrific rest of the day. Thank you.